Good morning, one and all. Thanks to Dr. Manju for having me here as a part of her course. I'm the foreign body here. What am I doing in a glaucoma session? Can I have a slide, please? So the topic is, how to manage ocular surface disorders that arise because of anti-glaucoma medications. So let's start with a case. This is a 71-year-old male who was referred to us in December. Long history of glaucoma. I mean, he was with us and many other places. Very, very irregular to follow up. Has been on medication since, as you can see, from 2005 on different kind of medications. He presented with itching redness in 2020. When we went through our old case record itself, it showed that 2017 itself, he was advised trabeculectomy and disappeared after that. At that point of time, the patient had 6/9 vision in both eyes. And this was how he was when he presented in 2020. Okay, his vision was 6/15 and hand movements, which was not improving at all. And this was his clinical picture. Both eyes, there was significant lid edema. If you see the lid skin, there was erythema, mild excoriation. Very angry looking eyes. Okay, red. The conjunctiva, because of the severe congestion. If you can see the lid margin, here, there is mild kind of whitish deposits, which is actually keratinization. Severe congestion. These pale white areas are the subconjunctival fibrosed areas. Okay, if you see the puncta is all closed off, stenosed off. There is no, semicircular fold here. Cornea scarred, superficial vascularization. Similar picture in the upper lid. Left eye almost same. Only the area of scarring is more and on different side. But then generally very bad looking eye on the surface. So what is happening here? Obviously, it's a dense cicatrizing conjunctivitis of both eyes with primary open angle glaucoma. Very advanced. So what is causing this here? And how will we, approach this case? Before that, yes, in an elderly patient with cicatrization, with such angry looking eye, always our first diagnosis is an autoimmune process, which is causing, progressive scarring, like a ocular cicatricial pemphigoid, or otherwise called as mucous membrane pemphigoid. Then there is another entity which is described called as drug-induced cicatrizing conjunctivitis, DICC, or pseudopemphigoid. Okay, these are cicatrization or scarring happening secondary to some insult which is happening on the surface. Okay, and one of the most common or causes the drug. Which one is happening here? So now, coming to our topic, I'm not going to details, but then it has been shown in many studies that almost 2/3 of the patient on long-term anti-glaucoma medication have developed some or the other problems with the ocular surface. And many studies have shown that arguably this is an ocular surface disease, and its symptoms are one of the leading cause for non-compliance of continued use of AGM in many cases. And because of the induced subconjunctival inflammation, scarring, and all those things, this can result, the surface disorders resulting from prolonged use of AGM can result in failure of drainage surgeries. So what is the pathology here? It is long known that preservatives and drug can affect the surface health. And yes, almost all the glaucoma medications have got some or the other preservatives. In addition to that, it is shown that the drug itself can cause a lot of changes. Okay, so it is not the preservative alone that is a culprit here. The molecule itself can cause the problem. Okay, so what is the problem these molecules cause? Whether it's a preservative or whether it's a drug, it induces inflammation. Okay, it induces conjunctival and subconjunctival inflammation through various different pathways. The whole lot of pathways described, but then all of them result in the final common gate. It results in inflammation, which results in scarring. That is the basic pathology happening here. And two important factors are the duration of the medications used and the quantity. As the number of medication increases, the possibility of getting surface problem increases here. Then another important factor is overlapping demographics. If you see, most of the patients who need anti-glaucoma medication are in the latter half. And if you go through the natural history of ocular surface disorder, especially dry eye, the latter, as the age advances, the prevalence of dry eye increases. Okay, so you have a group which is more prevalent with dry eye disease or surface disorder who has a glaucoma, and on the top of that, you're adding something that kind of disrupts the whole homeostasis on the surface. So existing dry eye will definitely worsen with AGM. If there is, even in cases where there is no surface problem, AGM itself can induce new surface problems and dry eyes. Again, it has been shown that chronic long-term AGM use causes structural changes in meibomian glands and the resultant insult on the tear film and other changes. Okay, versus the meibomian quality thins the lipid layer, resulting in what we call as SPKs or punctate erosions, lid margin changes, and so on. So all this, finally, what does the patient feel? Probably, kind of itching or irritation. There can be periorbital edema, erythema, chemosis, redness or hyperemia. Then as the duration increases, there can be subconjunctival scarring, lid margin changes, corneal changes like erosions, then vascularization, scarring are the results of, prolonged insult to the surface. How do you diagnose this? It's basically, clinical examination. Staining plays a very vital role here. You can pick up punctate staining, breakup time, Shermer's. These are the three common, simple clinical examination techniques which can be used by each one of us or everyone in the clinic. Then one thing which is very underutilized is questionnaires, ocular surface, OSDI, a lot of questionnaires are there which will show that as the time or the duration on AGM increases, the scores keep going up. Then how do you treat it? If possible, preservative AGM, and I believe that all AGM should be preservative free. Okay, please don't give preservative with preservative. Then there are studies which have shown that concurrent, start of tear substitute or lubricant with AGM will or bring about a good effect on the surface. And no financial interest here, but comparison of HPMC with sodium hyaluronate, people have shown that probably, sodium hyaluronate has a better role rather than HPMC. Then topical cyclosporin is another agent which can be considered to control the disease, or probably you can think about starting it early when when the patients start complaining about problems on the surface itself. Okay, these are two things which can be implemented very easily. Then in established cases where there is severe inflammation, we have to control the inflammation at the risk of getting shot in a glaucoma quorum here. You will need steroids to control here. Then the associated features. In this case, which I mentioned, we stopped the offending agent, put her on oral, Diamox, had to use steroids to control. We did a biopsy, and then Manju did valve in both eyes. Then finally, we did cataract, and this is how the patient ended up. Quiet eye, comfortable patient, happy patient, 6'9", 6'18" vision. Yes, prevention is always better than, treating it, but is it always possible? At least we can try. Preservative free. Take a detailed history. If there is a, history of suggestive of, some symptoms of dry eyes or surface disorders, anticipate worsening, start treatment early, and actively look for problems. I'm no way can suggest any of this, but probably, you can think about alternatives or medications early in the disease process, especially if there is no response to treatment to, disorders, or if there is progressive worsening. Thank you.
Thank you, sir. Thank you for the talk and giving some guidelines regarding the management of ocular surface where you don't have an in-house cornea person like me.